neurology, I'm excited to be able to introduce Dr. Anh Nguyen, who's also going to talk about advancements, certainly in medical innovation and technology. And so Dr. Nguyen serves as our fellowship director for the Houston Methodist Neurocritical Care Program and is a neurointensivist physician in the Department of Neurosurgery at Houston Methodist. He graduated from medical school, completed a residency in neurology and fellowship in the neurophysiology at the University of Texas Health Science Center in Houston. He completed a specialty fellowship in neurocritical care at University of California, San Diego in 2017. Dr. Nguyen joined Houston Methodist as a neurocritical care physician. He's board certified in psychiatry and neurology and neurocritical care. His passion for neurocritical care has had a huge impact on the continued development of the virtual Neuro ICU and Neurointensivist care program. Dr. Nguyen.
Thank you so much for that warm introduction. So, of course, today we're going to extend a little bit on my two colleagues' presentation, and we'll talk about more on the virtual Neuro ICU in terms of its advancement. So no talk on, of course, and I have no conflict of interest to disclose. Of course, no conflict of disclosure to, excuse me. The practice of medicine, though, in terms of going through the years, though, you can see this picture on the left here. Everyone recognizes it so well, though this is by Rembrandt back in 1632. You can see this is the anatomy lesson of Dr. Tulip. Going to the next picture there on the left, you see there, this is more what we're used to, bedside teaching, and we're still seeing a lot of this as well. Of course, now with technology, if people remember back in the early 2000s and late 90s, you have Palm Pilots, and back then medical students and residents would have all kinds of things uploaded on there. Of course, that's now replaced by phones, smartphones. And with EMR, now that it's getting better and better, things are getting more centralized through computers as well. So this, of course, is pre-COVID, and this is how rounds typically look like in the ICU now. Of course, COVID now has changed some of those things, and people are masked, and of course, we have to social distance appropriately during rounds as well. Taking this step a little bit further then in terms of what technology can bring. So now technology can serve as a way to outreach certain places, different countries even, not just within city, within state, but different countries as well. Share this breadth of information. And this is exactly where telemedicine comes in. And I know my colleagues spoke about some of this component already, the teleneurology, telestroke, with the mobile stroke units as well. We, of course, have tele-ICU, and then some other important things that will change care, of course, the pre-hospitalization component with EMS. So let's say if some of our paramedics go and have an interesting or very difficult airway, so they can actually have help, back up, someone to actually call in, if you will, and guide them through how to intubate these patients, how to manage some of these difficult patients as well. So why virtual ICU? So there's always been a national shortage of ICU physicians. So this is from CHEST in 2013. There's been many studies that actually showed this. There's different ways to how to remedy this. Of course, this poses as a staffing challenge. So you can try locums, but the problem with this, it's very costly, and you can imagine the care becomes very fragmented as well. The other studies showed that with virtual ICU, you actually have reduced mortality and ICU length of stay. What's quite interesting, though, with this is that the hospital length of stay actually doesn't change so much. And I want to just touch a little bit. This was actually published back in 2018 in our Methodist DeBakey Cardiovascular Journal. So not all virtual ICU has pros. There's some cons as well with it. So of course, with anything that's new, there's going to be some challenges getting buy-in from the staff, from the nursing staff, the physicians as well. And of course, there's an upfront cost with virtual ICU. Of course, in 2020, the big catalyst and the big driver in all this to expedite our Methodist program, of course, has been COVID. And if you can see at the head of the bed, that's actually me there. And what we're doing is we're manually proning a patient. So you can imagine now that as we get busier, and with already knowing pre all this that there's a shortage of ICU physicians, it's hard for me to manually do these things and yet still make sure all the protocols, all the blood pressure parameters in our next patients are in keeping with what we want. So having said about COVID expediting some of our virtual ICU timeline at Methodist, so what we have is in March, we, as in the Neuro ICU, we're the first ones to go virtual. This was joined a week later by Medical ICU. And then as you can see in May, we had SLICU join us. And then of course, the next up was our cardiac colleagues. In the future, we just have a couple more centers that we need to make and go live as well. And this is going to be Clear Lake and West. So just a quick introduction for our Methodist Virtual ICU team. So this is our command center, and there you have two of our nurses. And if you look closely, you may recognize one of our nurses is Claire and the other is Ken. The team is made up, of course, of our virtual physicians, who is responsible for a lot of the admissions, the codes until the support intensivist gets there, and coordinating the plan of care. The nurses that you see in the picture, they're responsible for many things, of course, monitoring, through sick bay. And what we try to do is we have our nurses here where we focus on their strengths. So we take nurses from the Neuro ICU, from cardiac ICU, and we assign them to those units. Of course, to make this work, we still have our APPs, our boots on the ground, if you will, our residents, and depending on the unit, our fellows as well. We have, of course, the bedside RN. And the program that we use here is called Caregility, and of course with Epic. Caregility is actually the camera that you see there. The thing that makes Methodist a little bit different in terms of the rollout of virtual ICU is we still have virtual intensivists. So our intensivist serves, we cover between units to basically put out any fires that may come about. Coordinate, of course, family discussions as well during this, and then help with the codes. So that was kind of just catching us up to where we are today with Methodist. So this talk is focusing on the future of virtual Neuro ICU and where it's going to go. Of course, again, this year has been very challenging, this last year I should say, but moving forward I think we're going to have a better idea of where this is going to go. So of course the goal here is to expand our care, expand our reach. We want to make sure that we have neurocritical care expertise, and we want to make sure that resource is allocated appropriately as well. The point here is to provide quality of care, not necessarily just quantity, because whatever we offer, of course, we know there is volume there. We want to make sure that we're able to do a good job and not stretch too thin. So to do this, there's something that I call the activation of the Houston Methodist neurointensivist team, okay? And we would be guiding a lot of these rollouts. And of course, we're having a fellowship here as well. We'll incorporate our fellows into this, not for the mere fact that they're another person that can provide this care, but I also believe that in the future, this is where this is going to go. And this also serves as a good introduction, a good experience for them as well. So how do we actually start with this? So the first component would be right here at Houston Methodist Hospital. Many times, as you can imagine, many of our stroke patients, many of our neurosurgery patients, they get overflow to other services, whether it be medical ICU, cardiac ICU, or surgical ICU, if you will. Whether it be because, again, bed overflow, whether it be because they have COVID now. So a lot of times things, despite our best efforts, do get missed by other intensivists because, once again, they're not neurocritical care specific. So we would take over this role and help co-management via virtual ICU. We make sure post-TPA, post-thrombectomy blood pressure goals are met. We make sure what to actually do when patients are going through vasospasm to prevent DCI during this time frame as well. So I think that's where we would start from to incorporate our reach there. Once we actually have a good handle on that, of course, it's to spread to our other satellite hospitals as well. Methodist is one whole system, and there's no reason that we can't treat it as such. And I think virtual ICU, this is the future, and this is the solution that will lend us there. So going through this, how would we make ways into this and to make this beneficial for everyone? So I want to point out some of the data. This is from 2020. I looked at the data in 2019. More or less the numbers are about the same. You have to take some of these numbers again because of COVID, but 2019 were about the same. So if you look at the numbers on the left, these are the neurosurgery, and on the right it's the neurology requests for transfers. So for 2020 up until October, you have 634 patients, whereas neurology you had 360 patients. On the blue there, you see we take a majority of these patients, but what I want you to focus is on the red. So for instance, during neurosurgery, there's a big chunk of patients that did not come here, whether it be their outside network, but looking at this data more so, a lot of times it's because of bed availability or something else. So our goal in this is how do we actually keep these patients within the Methodist system, but yet still provide with them the quality of care that they deserve. So to do this, we start with the transfers. So same thing, we would use tele-ICU to actually see these patients. So the first case scenario you can see in the emergency room, they come to one of our satellite hospitals, for instance. We have a 50-year-old gentleman, no past medical history whatsoever, and he has headaches now, and he mentions to us that he had a mechanical fall, and he has headaches, and because of that, it concerned him, and he presented to the emergency department. So sure enough, we obtain a CAT scan there, and you can look, he has a left frontal traumatic subarachnoid. There's nothing else. So during this time, you can imagine the ED physician there can ask us for our opinion. What we do is we can call in through our virtual ICU. We evaluate the patient with the help of the nurse, just like what we would do with stroke care. We examine the patient, we talk to the patient, we talk to the ED physician, and coordinate the care. We see this patient, he's neurologically intact, no other issues besides a mild headache. We say, let's repeat this CAT scan in 6 hours, which is the same care that we would do here. And in that case, that patient would actually stay at that satellite hospital and not need to be transferred over here. The second case here, this is a little bit more laborsome, but I think with the appropriate work, we can actually get there as well. So this second case, we have a 60-year-old gentleman, or 60-year-old female, excuse me, with a past medical history of uncontrolled high blood pressure. She presents with acute onset right-sided weakness, and per EMS, her blood pressure on arrival was greater than 200s. So she too gets a CAT scan. And what we see here is a very small putaminal ICH. So it's far enough from the ventricles that you're not so concerned about any IVH or hydrocephalus that will ensue. The management here, as we know, of course, will be good blood pressure control, make sure she gets good PTOT, make sure that there's no other medical issues that she has, developing pneumonia in the hospital, UTIs. So those things, you can imagine, not only being seen in the emergency department, but once she's admitted, if we're able to coordinate this care, make sure her blood pressure is controlled, make sure she doesn't develop renal failure or any of these things while we're treating the blood pressure, I think many of our hospitals and our hospitalists would be okay actually keeping these patients there. The other point that I want to make about virtual ICUs that's so important though, it helps us with our protocols. And again, it's the practice of medicine, it's the art of medicine. Every patient's a little bit different, but actually having protocols is very, very beneficial in itself. It makes sure that, of course, our best practice guidelines are there, everything is evidence-based. There will be less variability in care, and especially if we're branching out to all our sister Methodist hospitals, we want to make sure care is relatively the same from everyone, and of course, decreases any risk of fallouts. The next couple of slides, we're not going to go through so much, but these are some of the sample protocols that my colleagues and we've made, and we've gone through intensively in the past. So this is one about ICPs, about what to do. Of course, if there's concerns with EVD monitors, what to do in terms of titling the, making sure the waveform is correct, how to use and when to use hyperosmolar therapy, and things that can be done at the bedside as well. So with this is just for ICP crisis, but we have this for non-traumatic ICH. You can imagine post-thrombectomy bleeds, for instance, as well, status epilepticus. So anything that, the most common things that you can see in ICU care, we can actually have a protocol for. And with that, I actually want to touch and highlight one other thing, and that's the research that this offers. Having now a collaborative system now only offers more communication, better communication, and also to joint data and to leading in terms of better research. As a matter of fact, some of our nursing staff have already started publishing and writing abstracts from our experience here at Methodist with the support intensivist system as well. One poster is entitled Expanding Our Horizons, and that should be published soon. And that concludes my talk there.